This is the first session, or I guess I would say podium session. I'll be moderating this one. This is on medical management of the trauma patient. With me is, again, Dr. Vilella. We also have Dr. Mark Seamon and Ola Sjoholm, who are trauma surgeons here in Philadelphia. And so we have 2 orthopods and 2 trauma surgeons, and we'll go through some cases. These are my disclosures. These are some of the things I want to make sure we get through. Primarily, how do we manage ortho injuries in the context of multiple trauma? And I think the issue that comes up the most is, timing, appropriate prioritization, et cetera. We'll touch a little bit on, maybe how things are a little bit different or not with gunshot injuries. I want to talk a little bit about, the evolution of resuscitation and pelvic fractures and how these are managed and triaged. And then a little bit about DVT prophylaxis and maybe how that's also changing. So first, I'm going to take just a couple of minutes to go through some didactic stuff, and then we'll get into some cases. So a couple of things about prioritization and timing. Over the last 20, 30 years, we've gone from a model of early total care and sort of addressing everything at once to, the damage control orthopedic model, which was really a lot of staged management. And now we're sort of in this pendulum has swung back to the middle a little bit, where you sort of have this early appropriate care model. And I'll kind of mention what that really means, and perhaps we're still headed somewhere else. So this term has come about, I would say, in the last 5 years, 10 years, or maybe closer to 5 years or so. And it's really simplified things. A lot of the damage control literature looked a lot at IL-6 and, labs that a lot of our centers really don't use as a marker of inflammation, and instead kind of focus a little bit more on lactate levels and using that as a guide to resuscitation. And I think to summarize this kind of, swinging back of the pendulum from staging everybody with X fixes and then kind of waiting to definitively fix them, where, we now are trying to get more definitive surgery done earlier, as long as, some of these parameters are met, amongst other things. I'm just not going to go through all the literature, just a couple of other papers, relatively recent, showing that, lactate level is a good marker to some extent to seeing how you can avoid staying out of trouble, especially with pulmonary complications and patients not getting off the vent. Question comes up sometimes of, you got multiple injuries. Can you treat, do multiple procedures at the same time? And again, this is another paper out of Metro Health in Cleveland, where they're really kind of sort of bucking the damage control model and saying that we can do these earlier and we can probably do more cases early on and get patients moving faster. Couple of words about pelvic hemorrhage. I'm not going to go through all the abstracts or stuff, but just throw up some of the recent literature that we're seeing around the world on use of the hybrid room, use of, looking at, do we really need to send everybody with a blush to the angio suite where they sit there for 2 hours, or are there other ways to manage this? What about packing? Obviously, there's some centers and some parts of the world where this is done more than others, but the literature is compelling. What about Reboa? And do we really need to rethink about what do we do with these patients who have a pelvic blush? And some multi-institutional trials have tried to look at this. So we'll talk about that in a couple of cases. Last thing is, how to best prevent VTE. This is from the New England Journal. So I think it's probably worth at least being familiar with the study. It just came out. We've been using Lovenox for so long, and this really looked at orthopedic cases that are higher risk, hip and knee replacement and hip fractures. So certainly higher risk than like an ankle fracture, let's just say. So at least in the orthotrauma world, these are the high risk patients, and they randomized rivaroxaban to enoxaparin and found that there was actually a slightly decreased VTE rate with rivaroxaban. It's an oral medication. Maybe we should consider using it, especially for our extended prophylaxis. I'll just throw it out there. I was actually recently approached just last week by Dr. Sjoholm's group saying, look, in Pennsylvania, Trauma Quality Improvement Project is very concerned about underdosing Lovenox. And I know that this is a hot topic in the trauma world now, that maybe just giving like 30Q12 or 40Q day is underdosing a lot of patients, and we should maybe consider a weight-based dosing for prophylaxis. And finally, I would also say that you should probably consider uninterrupted prophylaxis in isolated trauma. And this also comes out of this guideline, but it's something we've been doing. Because think about it, and you have a patient, if you hold anticoagulation, right? So they come in, let's just say a hip fracture, comes in 11 o'clock at night, you hold anticoagulation, they don't get cleared. So now someone forgets to restart it, and then it gets held again. And now you have a patient in the hospital 2 days, really high risk for DVT, and they didn't get anything because you held it pre-op. So many of us have found that you don't need to hold it pre-op. So we'll get into the cases, and feel free to, I'm not going to be able to sort of see the chat room in real time. I'm going to rely on Dr. Vilella and Thoder to step in if they want to interject a question that's come up that's important. I will be looking at it during the next session to try and address any questions, but we're going to poll the panelists as we go through this case. So here's a 32-year-old male, type 3A open femur fracture, left distal radius, pneumothorax, rib fracture. So he's got head injury, chest injury, facial fractures, kidney injury. So a lot going on. So actually, I'm going to pull up a poll here. So all the participants, I want you to just go ahead and answer this question. What's your next step? Okay, what are you going to do next? And I'm going to just go back and show you the case. 32-year-old male, open femur, distal radius, chest injury, head injury, facial injury, abdominal injury. What's your next step? You're the orthopedic surgeon. What are you going to do? Okay, and we'll give it another 3 seconds to please vote. It looks, what I'm seeing here, I'll just read it out if you can't see it. Urgent operative debridement and ex-fix was by most of you, but certainly some other choices were selected. Dr. Seamon, what do you think?
That was my choice. I think for this patient who's a polytrauma patient, multiple body cavity injuries, including significant chest wall injury, pulmonary complications are very likely. So an urgent ex-fix and operative debridement for the open fracture, along with early antibiotics, is definitely my choice here.
Okay. So that patient goes to the OR, does get a debridement, ex-fix of the femur. Lactate was 4.8 on admission. There's your ex-fix. Hospital day 1, desaturates overnight after repositioning. SATs still aren't perfect. Maybe the patient's better resuscitated, but the impression we're getting is not okay for the OR. So Dr. Vilella, how much are you, so you're rounding the next morning. How are you involving the opinions of your trauma team, your SICU team? Like, what's in real time? How are you, I don't even know where this comment came from, not okay for the OR. What do you do in this situation? In terms of communication and like working with your teams.
Okay, can you hear me?
Yes.
Okay, so I think in this particular patient, I think, you know, obviously open femur fracture, chest trauma, but I think there is a really big need to involve the neurosurgeons in this because of the head trauma. Sort of the head trauma throws a curve to everybody. In terms of my involvement with the opinions of the trauma surgeons, we really have a really good trauma surgery service in our institution. We respect them a lot. They control the patients as much as possible. We try to be as interactive as we can. And it's always incredible when you talk to the trauma surgeons about these patients and address the physiologic problems as they do in terms of the orthopedic injury. My involvement usually is rounding in the ICU and calling the attending in charge of the ICU and see sort of press, but not press too hard to take this patient to the OR as quickly as I can. So they're in command at our institution.
Okay. Ola, are you there?
Yep.
Are you now, you look at the literature and a lot of times, you know, we use trauma scoring systems and, you know, a lot of studies look at, you know, how timing should be addressed in terms of, you know, like a reamed femoral nail in a patient like this, and you sort of correlate with trauma scoring. But to what extent is that used at the point of care? Is it used at all? I mean, you know, you have a database, these patients that come in, I'm sure those scores are being scored, but how is it used in real time? Is it at all?
So I don't use the trauma scoring at all prospectively, taking care of a patient in real time. I think that's more from data collection standpoint, and I'm not using it at all. I have a little bit different approach to this patient. Is this one of our patients here?
Yeah, I know this patient very well. Yeah, he's a patient of ours a couple years ago.
Because it's really hard to see, you know, be black and white about these patients, obviously. If this patient has a simple pneumothorax, a small subarachnoid hemorrhage, and a little ding to the kidney, and otherwise completely stable, I wouldn't be so opposed to go for this patient to go, so to say, urgently to the OR. I'm not sure what urgent is, but that's within 6 hours or something.
Mm-hmm. But he's been X-fixed. So he got X-fixed on the night of admission.
Yeah. But I wouldn't be totally opposed for him to have a definitive surgery if he's otherwise completely stable and all the parameters are normal.
Okay. Yeah, I mean, and I think, you know, what Nano said is good. You know, a lot of times if you're thinking one thing and you're hearing the patient's not okay for the OR, sometimes it could be just, you know, I don't know, could have come from the resident covering overnight who was covering 5 other things, and that's just their first reaction to tell you.
Based on what I see here, not okay for the OR, I'm not sure what that was based on.
Right. But I mean, that'll often be like the message you get, not okay. All right, well, you know, and, you know, it's just a real thing. You kind of have to decide how to handle that information and maybe communicate at another level. Ola, does anything change if this was penetrating? Like same patient, injuries, well, maybe not the facial fractures, but like, is there any?
So he probably wouldn't have a brain injury. He could have a chest injury for sure. Not really.
Yeah,
no,
not really. Right? No. You look at the overall picture. I mean, you know, we're not, you know, shotgun injuries, sure. Maybe we're dealing with, you know, massive soft tissue.
Is he adequately resuscitated? Lactate has normalized. I think this patient should go for his definitive surgery as quickly as possible. Certainly if he has acute lung injury and bad pulmonary contusion or really bad brain injury, that put the whole thing into a different situation.
Yeah. So, I mean, a couple of strange things happened with this case. So, I mean, he's got the X-fix. He actually goes to the OR, has his wrist fixed. And I would say, I think on paper it doesn't really make sense. But sometimes, you know, some cases get done due to availability of certain surgeons, and maybe the hand surgeon was available. Maybe the trauma surgeon who likes to do distal radius fractures, you know, I'm talking about, was ready to go in a room that wasn't able to handle a femoral nail, and it's just like this wrist needs to get done, let's get it done. So sometimes funny things happen like that still move along care, but maybe in a presentation don't make sense when you sort of think about it. I think we discussed this already, handling timing for sure. And Nano brought it up, Dr. Vilella, initially about, yeah, you got to talk to neurosurgery. I mean, the problem with head injuries is, you know, we don't really have great protocols for this. And in fact, most of the papers that talk about this say, you got to talk to neurosurgery. So it's really just, you know, a case-by-case thing with communicating with the neurosurgeons. Are they comfortable with this patient, you know, traveling to the OR and, you know, being flat for a period of time? So to move this case along, because, you know, this meeting I am going to sort of, the sessions are going to feel really rushed for the moderators, and, you know, myself included. We're going to try to keep everything as close to on time as possible. So I will certainly not get through my slides. This patient gets the X-fix removed, gets a retrograde nail, actually hospital day 8. And certainly wasn't, I would not say wasn't really going anywhere anytime soon. So I don't think his care necessarily was delayed. But here he is 5 weeks post-injury. This patient happened to develop a ton of heterotopic, or I would say excessive callus impeding his quads, and end up getting some resection of that heterotopic bone as a side note. Another case, 45-year-old male, dirt bike versus auto accident out on the street on Broad Street. Open femur again, with an open knee, foot injuries, and then the right thigh is amputated in the field, actually. So there's massive blood loss, hypotension on presentation. Again, the right lower extremity is gone, and the left lower extremity's got an open femur, an open knee, and some foot fractures. So pretty bad extremity injuries, and the extremity injuries to the point of, you know, pretty massive blood loss with that other side. Gets an X-fix, gets an IND, gets cleaned up, gets that stump on the other side addressed. So hospital day 2, patient goes back for repeat IND of that knee. The right lower extremity, there's an AKA stump, it's open, it's still getting cleaned up by plastics. Dr. Vilella, IM nail now?
I think actually I would prefer that the patient be, his wounds actually be a little bit cleaner. You know, if he's still undergoing irrigation debridement, his patient's probably in the ICU, has an open wound. He's probably either getting bacteremic or will get bacteremic. I think the X-fix has provided stability to provide the soft tissues from having any further damage. I would probably not wait a little bit on the IM nail.
Yeah, I would say, and I would, that was our thinking here in this particular case. You know, the sort of other side kind of made me a little nervous too. And I think a lot of us as orthopedic surgeons, once the patient has the X-fix on, you kind of like take your brake off the accelerator a little bit and you say, well, you know, bone is stabilized, patient technically can be mobilized, they're not tied into traction. And I'm thinking, I'm more worried about pin sites getting infected and, of course, getting their definitive surgery done, which is just obviously better for the patient. So let's, I got another audience response question here. So you have this, you have a polytrauma patient, femur fracture, lactate is normalized after 36 hours, but they're still somewhat hypotensive. So please go ahead and answer this question. What do? Do you wait another, I'm not talking about this case, I'm talking about a case. Femur fracture, lactate's normal, still somewhat hypotensive, making urine. At 36 hours, do you wait another day? You X-fixing them, or just go ahead with a nail? Give another 2-3 seconds. So hopefully y'all can see that. So it looks like, I don't see the bar showing, but most of you said go ahead with IM nail. I don't know if you can mostly see that. What do you think, Dr. Seamon?
Again, that was my choice, but I think it depends on the perceived physiologic insult, which you know, could be very different among patients. you know, an 80-year-old versus a healthy 20-year-old football player. So in general, though, I think nowadays proceed with IM nailing, and that's what I would tell the orthopedic team who's rounding on our patient in the ICU.
Yeah. Yeah, because I mean, I would say like in this case, I don't have an X-Fix on. It's 36 hours now. And so in this case, I'm like, well, what does somewhat hypotensive mean? And, you know, is that something that can be kind of quickly addressed or, and we can move ahead? But yeah, depends. Last case, as we wrap up, auto versus motorcycle. A lot of stuff to process there. Basically just multiple trauma, right? And this time we have a pelvic fracture. There's a femur fracture. Actually, it's a closed femur fracture. And you have an APC2, there's a blush on CT. Patient's hypotensive. Dr. Sjoholm, what do you, I mean, the patient has some free fluid. They have to go to the OR with you guys. They're a little bit hypotensive. Tell me a little bit about your thought process when deciding to take a patient to the hybrid room versus like 5 years ago.
Yeah, I think this particular patient would be very well suited to go to the hybrid room. I guess the patient was stable enough to go to the CAT scan pre-op, so we knew that there was a blush in the pelvis, yep. And also had some free fluid and needed an exploratory laparotomy. It looks like he has an open book fracture there too. So this is a perfect patient to take to the hybrid room. And our IR people, they don't mind coming there to join us. Initially, we got some pushback and they felt uncomfortable going there, but now they feel more comfortable, and we have done multiple cases in our hybrid room. So this patient is a perfect patient to bring there.
Dr. Seamon, have you guys had a similar experience?
Yeah, we have. I would just add that even though the usual scenario is that we don't have a CAT scan, the patient's too hypotensive to go to CAT scan, in which case they would go immediately to the OR based on the FAST examination, which, you know, and this one would be positive. And then pre-peritoneal packing, and you mentioned one of the real landmark papers from Clay, Coughlin, Burler, is really effective in this. About 80 to 90% of the leading from pelvic fractures, of course, is venous in origin, and the pre-peritoneal packing really addresses that fairly well. And then you could proceed with your laparotomy, you know, through a different incision.
Yeah, so I think this is an interesting concept. I've seen more cases getting addressed in this way in the hybrid room. Just to wrap this patient up, they did get an X-fix for their closed fracture. We felt the pelvis in that particular case didn't need an X-fix, but you can see a whole lot going on. We're out of time, so maybe if I can ask my panelists to comment in the chat room, if you don't mind, as we move into the next session. Just your thoughts on DVT prophylaxis for these patients. You heard me talk about Lovenox and weight-based and rivaroxaban. Please share your thoughts, and I will kind of wrap this up. Obviously, I had enough cases in case we moved faster. These were the things we wanted to discuss. I hope that the objectives were met. I talked a lot about timing, a little bit about pelvic fractures, and certainly some didactic stuff on the other two slides. Not so much in the cases, but we'll hear the comments from our panelists. I want to thank you guys for joining, and we'll move on to the next session. Thanks.
Thank you.
Listen, I'm going to try this clap thing.
Thank you.
Work?
Oh, much louder this time.
It's just the way I got to use my mic. This is what's missing from the Zoom meetings. They have to have a clap button. You feel like it ends and then, like, you know, now what? Okay.